So let's see this post-operative complication. What are the physiological changes in surgical complications? Post-operative can be depending upon immediate, that is early or late. This can be classified according to underlying cause, whether it is hemorrhage, pyrexia, venous thromboembolism, wound complications. Complications specific to the operation, leak of the prosthetic material, or there can be complication related to. So the risk factors are age of the patient, obesity, cardiovascular disease, respiratory, diabetes, and all this. So complications may be immediate or early. Immediate complication occurring within 24 hours after surgery. These are occur. Early complications in definition within 30 days period is called to be late, and late discharge from the hospital and more than 30 days. General complication surgery is hemorrhage. Primary hemorrhage is during operation. It can be controlled before the end of operation. Primary, reactionary, secondary. This is the very important thing. Reactionary is first few hours after surgery. Clot is dislodged. This is first view. And secondary hemorrhage is after number of days after operation, usually infection related and sloughing of the clot or erosion of the ligature. So that is secondary hemorrhage. Primary is on table, or reactionary is dislodge of the clot within hours and within days. Predisposing factors are obesity, steroid, jaundice, recent blood transfusion, stored blood, disorders of coagulation, platelet deficiency, anticoagulation, old age. How to prevent hemorrhage? Recognize the patients which are at risk, reverse the risk factors if are there, control the infection, meticulous surgical technique. Management of hemorrhage, resuscitate, correct coagulopathy, consider blood transfusion, packing may be necessary. Post-operative fever, common complication, consider it is correct measurement, how the temperature is measured, what is the trend, whether it is new persistent elevation, swinging, is it due to infection, deep vein thrombosis, low grade pyrexia, compartment syndrome, like this. Is there evidence of systemic involvement, rigor, shivering, or what? It is necessary to related to drug or what? Recurrent cultures. So different causes tend to manifest at the different time points. So these timelines are important for post-operative fever. Day 1 to day 3, most common causes of fever are 1 to 3 is atelectasis is the most common, then maybe metabolic response, drugs, systemic influence response, or line infection. 1 to 3 days. Then after 4 to 6 days, atelectasis is a basal lung infection, and 3 days there can be chest infection, superficial lung infection, line infection, urinary tract infection. Day 7 onwards there can be chest infection, anastomotic leak, deep vein thrombosis, or deep abscesses. Investigations to rule out post-operative fever is WBC count, neutrophil count, CRP, septic screen, blood culture, urine analysis, wound. Note, in 24 hours after surgery, CRP will almost be raised due to trauma, so should not be measured routinely. An upward trend of CRP in measurement is a sensitive marker. Single measurement is not there, upward trend has to be important. What are the wound complications? Depends upon the type of operation, potential contamination of the operation, contaminated operation, dirty operations. So, obesity, hematoma, diabetes, steroids, malnutrition, obstructive jaundice, foreign materials, grafts, all these may lead to prophylaxis of wound infection, whether you identify the patient risk, control risk factor, meticulous surgical technique, antibiotic prophylaxis, bowel preparation. Treatment of the wound complication, ensure adequate drainage, send fluids, pus culture, sensitivity, appropriate dressings, antibiotics only if infection is there. Abscesses, drain it, septic shock, early cicatrization, treat and remove the source of infection. Septic shock, complications of infection. Complications of GI surgery, there can be anastomotic leak, visceral injury, or gastric dumping syndrome, all that. Complications of vascular injury, cerebral vascular accidents, hyperperfusion syndrome, patch dehiscence, cranial nerve injuries. Aortic repair, damage to adjacent structure, renal vein, prosthetic infection, ischemic colitis, impotence, spinal ischemia. Arterial bypass, anastomotic leak, rupture, graft versus foam failure, compartment syndromes. Venous injury, damage to the nerves, deep vein thrombosis. Complications of cardiothoracic surgery may be arrhythmia, anastomotic bleeding, blowout, low cardiac output. Pulmonary surgeries, leak of the air, atelectasis, bronchofistula. Complication of orthopedic surgery, prosthetic infection, joint dislocation, pre-prosthetic fracture, malunion, non-union, DVT. Complications urology, there is hemorrhage, arteriovenous fistula, urinary leak. Ureteric surgery, stenosis, obstruction, bladder, ileus, rectal injury. Then complication of plastic surgery, scarring, flap failure, necrosis. Complication of breast surgery, damage to axillary structures, axillary nerves, seroma formation, lymphedema, lymph nerve damage. Rehabilitation surgery ultimate is to success surgery. However, this does not mean that getting patient off the operating table. It includes post-operative care, rehabilitation during time, eventual getting back into the community. That will be the end. What is the physical injury? at operation, what is the outcome of effect on the physical state, what is the existing homework situation. Things to consider include multidisciplinary team, patients, relative nurses, physiotherapists, social services, transport facilities, home. Specific rehabilitation needs. Some injuries or procedures have specific rehabilitation. For example, multiple trauma, head injuries, trauma patients, amputations, they need rehabilitation. Consider the following: age of patient, understanding long-standing analgesia, idealistic goal settings, early physiotherapy, occupational therapy, self-employed, and all these things have to be considered. Stigma of being sick, psychological issues, psychiatric issues has to be given. What are the first thing is respiratory failure, post-operative respiratory complication. Problems are very common following surgery. Risk factor include patient anesthesia, perioperative trauma. Patient risk factors: more age, having history of smoking, obesity, prevalent cardiac diseases, immobility. Anesthesia factors: reduce residual capacity. Reduce residual capacity resulting in supine position and raising of the diaphragm. Ventilation perfection mismatch, increased shunt perfuse, not only vented, increased dead space ventilation. All they lead to one lung ventilation, excessive sedation, residual anesthesia agents. They may lead to infection. Post-operative factors: upper abdominal incisions, analgesia, sedatives, pain restricting respiratory. Trauma factors: spinal cord lesions, analgesia, rib fractures, pneumothorax. Common respiratory post-operative pathology: basal atelectasis is the most common. Bronchopneumonia, pulmonary embolism, effusion, pneumothorax. Investing post-operative respiratory problem: chest X-ray is the investigation. ABG may give signs, ECG to exclude cardiac cause, management of post-respiratory problem, risk factor corrected before surgery. Adequate post-operative analgesia, minimal sedation, physiotherapy, mobilization, antibiotics, drain effusion, ventilatory support. Now renal problem: kidney have multiple function, homeostasis, extracellular fluid volume. Kidneys: water, electrolyte, excrete waste, metabolism, dehydration, endocrine, renal aldosterone system. So nephrons, there are 1 billion units of nephron. The structure of nephron is coiled. They have a Bowman's capsule. Total available for filtration is 1 meter square. So you can see this has large area for filtration. This is important figure. So what is there? You can see the osmolality gradient. At the bottom, it is 1200 milliosmoles, and at initially ATP driven, 70% of sodium is absorbed, passive hydrogen and chloride in the proximal convoluted tubule. So here sodium is absorbed, so passive influx of the sodium. Then in descending, sodium goes down again. So what happens? Osmolality increases it to 1200 milliosmoles per liter at the bottom. Osmolality reabsorption. So water is absorbed in the descending. Active solute removal. Here in this there is active solute removal. Concentration of urine becomes dilute. As it rises up, it becomes dilute. So distal convoluting tubule, active sodium reabsorption again takes place. Water is reabsorbed by osmolality, and at the end it will be 300. So what is there? It goes with 300, then again 1200, then it means counter current mechanism. So you can see from 300 in between it goes to 600, then 900, at the bottom is 1200. So whenever urine is going out, it is around 300 ml. So this is the osmolality gradient. Bowman's capsule on the capsular to collecting ducts, eventually draining into the ureter. Initially ultrafiltrated from the Bowman's capsule, drained to the podocytes. Food process in the capsule and proximal convoluted tubule leads to the loop of Henle with both thin and ascending loop of Henle, thick loop. Subsequently, distal convoluted tubule joins the collectum where the limbs into medulla and medullae at each stage progressively modified. Therefore, two types of nephrons with different functions. Supracortical nephrons, 80% are cortical nephrons, are glomerular lying close to the kidney surface, and juxtaglomerular nephrons, it is 20%, we are lying deep to the medulla. They are accompanied by vas recta and capillary nephrons. They are involved in countercurrent. Mechanism that maintains the high solute concentration renal medulla. Ultrafiltrate is modified in the tubule by combination of passive and active processes. Three sodium ions are directly transported out of the lumen by exchange of 2 potassium. ATP driven ion pump in the tubule wall. This creates an electric sodium gradient, encouraging simple diffusion of sodium out of the filtrate. Other compounds such as glucose, chloride also are reabsorbed in this way. Sodium carries proteins pull molecules. Sodium ion, this is called as co-transport. So initially, water is drawn from the tubules. Summary of filtrate modifying proximal convoluted tubule. What happens? Absorbs 65% of the filtrate. Line and brush border of villi and mainly transporters both absorb and secrete. So sodium, chloride, water, glucose, all are absorbed. Organic acids are reabsorbed. Loop of Henle, descending site of simple diffusion. Water is just diffusing. Loop of Henle, ascending, again sodium and chloride. So ascending and distal convoluted tubule is chloride. Proximal convoluted tubule is glucose co-transport. And at collecting duct, aldosterone is acting to absorb sodium and chloride as well as water. The degree of urinary concentration is controlled by ADH renal hormone direction. In absence of ADH, the ascending loop of Henle is collecting to the relatively impermeable to water. So higher proportion of water in the filtrate is excreted. Concentration of urine is performed by countercurrent concentration. This is the question. Concentration of the urine is performed by countercurrent mechanism and occurs in long loop of Henle of juxtaglomeralar apparatus. The renal medulla has very hyperosmolar interstitial fluid maintained by active transmission. As a filtrate passes down loop of Henle, water is drawn by high medulla osmolarity, and this ascending loop of Henle chloride are actively transferred filtrate under the influence of ADH. Distal convoluted tubule collecting ducts become highly permeable to water. This portion of nephron passes through the hyperosmolar medulla, so allows reabsorption of additional water and concentration of the urine. So net flow across the movement capsule is GFR. What is GFR? This is the net flow of the great functional reserve. Respiration of GFR is 125 ml, around 180 liters per day. So GFR depends upon the hydrostatic pressure in the glomerular capillaries. First is glomerular capillary pressure and Bowman space. Fluid hydrostatic pressure is higher in capillary in promoting filtration. Hydronephrosis causes increased hydrostatic reducing difference between the two. So one is hydrostatic pressure and second is colloid osmotic pressure. So they oppose each other. So hydronephrosis decreases GFR. Colloid osmotic pressure between Bowman's capsule and this. So ultrafiltration coefficient is constant relation to the area conductivity of the basement membrane, hydrostatic pressure, resistance, efferent, afferent. Afferent vasoconstriction decreases GFR, glomerular plasma flow. Efferent reduces plasma flow. Afferent vasoconstriction decreases GFR and glomerular plasma flow. Therefore, efferent vascular constriction reduces glomerular plasma and also increases GFR pressure as increasing GFR. So whenever efferent is there, autoregulation holds the glomerular filtration rate to 88 element of Hg. Juxtaglomerular apparatus, it has got tubuloglomerular feedback, another mechanism by which GFR is regulated. The negative feedback mechanism whereby GFR is inversely related to fluid delivery to distal nephron. It is controlled by specialist cells in juxtaglomerular apparatus. Juxta are located in the initial portion of distal convoluted tubule. Macula densa, juxtaglomerular, extraglomerular mesenchymal. So this is present in the distal convoluted tubule juxtaglomerular apparatus. Juxtaglomerular cells, macula densa, juxtaglomerular, extraglomerular, mesenchymal. They contain three types of cells. Macula densa, tubule involved in feedback. Juxtaglomerular cells, smooth muscles, arterioles secrete renin. Renin is secreted by juxtaglomerular cells, smooth muscle cells of arterioles, extraglomerular mesenchymal cells. GFR is measured externally administered by inulin, and endogenous it is by creatinine. So solute concentration in urine divided solute concentration in plasma into urine volume. So diuretics, mannitol mainly increases excretion of sodium chloride and water. Diuretic working by the increasing urine volume. Thiazide decreases sodium absorption. Distal convoluted tubule, Lasix loop diuretic decreases transports parenteral aldosterone antagonist. Renal hormones and their action. ADH, arginine, vasopressin. This hormone is produced by cells of supraoptic nucleus of the hypothalamus. This is another question. Isolated in posterior. Decrease in blood pressure sensed by baroreceptor in the great vessels, decrease BP, decrease in circulatory volume stress receptors, decrease volume. Alcohol, opiates, and prostaglandin, estrogen, stress all decrease ADH secretion. So opiates and they decrease the ADH secretion, which acts to increase salt and water reabsorption, and this causes this concentrates the urine and reduces its volume. Or urine volume is reduced and concentrated. Renin-angiotensin system produced stored in the muscles by juxtaglomerular apparatus. So angiotensin 1, angiotensin convert to angiotensin 2, it causes vasoconstriction, kidneys decrease sodium absorption, suprarenal increase aldosterone, sodium reabsorption. So antenatal is the reverse of that. Renal failure, oliguria less than anuria is oliguria is less than 0.5 milligram, and only absence of urine output. So it can be prerenal, renal, post-renal. Prerenal is the causes of hemorrhage, shock, GIT, dehydration. These are all renal. Inadequate perfusion of kidney is common cause of renal failure in the hospital. Hypovolemia is classified according to etiology, loss of blood hemorrhage, loss of plasma in burns, loss of crystalline dehydration. Note the possibility one of the replaced with the blood for hemorrhage, 5% or water in dehydration. However, in many hypovolemic state, priority is initial rapid loss circulating blood, collide, arsenic crystallite, normal saline. Typical mechanism is hypoxemia and hypoperfusion, reduces sodium absorption, ascending loop of Henle, and thereby increases high energy consumption. Hence, juxtaglone detects increased filtered sodium and therefore reduces renal blood flow to conserve the blood volume. Renal causes of renal failure, intrinsic renal pathology, acute tubular necrosis due to prolonged ischemia of tubular toxins, including drugs like gentamicin, glomerulonephritis, vasculitis seen in vaginous granular, Goodpasture syndrome, anti-glomerular base membrane antibodies, vascular lesions, hypertension, emboli, thrombosis. Post-renal causes obstruction to the flow of the urine, may be unitract, pelvic junction obstruction or bilateral junction obstruction, blocked catheter, cervical portion. Nubula. Most important cause of renal failure that must not be missed because so easily treatable, hypovolemic dehydration and post-renal prostate catheter problems. Prevention of renal failure, renal hypotension, hypovolemia, dehydration, sepsis, NSAIDs, necrotoxic drugs like NSAIDs and gentamicin. In all cases, monitor renal function closely. Substitute the drug with the nephro. If there is indication, prophylactic intervention, sodium contrast medium. Assessment of acute renal failure differential is that history examination, urea creatinine levels has to be taken, major metabolic acidosis, paired urinary serum. Paired urinary serum measures osmolality of sodium. Response to fluid challenge between pre-renal and renal causes has to be done bladder urine analysis. What you can do is that if it is pre-renal or renal, if urinary sodium is high, it means urines, it is losing the sodium. If it is low, it means renal cause. Less than 20, it means pre-renal. More than 40, it is urine. Now serum osmolality ratio, urine to serum osmolality ratio. Serum osmolality is more, it means it is sodium is serum creatinine ratio. Urine osmolality, if it is renal, then it will be less. If it is pre-renal, it will be more. So this is about management of the renal failure. Preview of the drugs for the patient, NSAID, optimization of serum biochemistry, renal failure. You have to check following biochemical commonly occurs in rise in urea and creatinine. There is hyperkalemia, hyponatremia due to relative water overload. Acidosis, hypocalcemia, hyperphosphatemia. So treatment is hyperkalemia, treatment is calcium chloride. First important point is calcium chloride. Does not reduce potassium level but reduce risk of cardiac. First is cardiac, then insulin. First is calcium, then insulin, then bicarbonates, salbutamol, calcium resonates. These are the treatment of acidosis. This can be treated by including soda bicarbonate infusions. Nutritional requirements has to be high calorie diet needed. Treatment of infection in the patients. General replacement, renal replacement theory, hemodialysis more than, if potassium is more than 5, pH is very much low, acidosis there, pulmonary edema, blood urea, serum creatinine. Methods of renal replacement, continuous arterial hemofiltration, continuous venous infiltration, hemodialysis. These are the different methods: hemofiltration, dilution. Ambulatory Teknov's catheter is passed, systemic inflammatory syndrome, one of the two factors. Just remember the heart rate, 2 or more than 2. Heart rate more than 90, respiratory more than 20, or PCO2. Respiratory rate more than 20, heart rate more than 90. Temperature 38 or 36, and WBC count 12 or less than 4. These are the systemic. Cytokines involved are inflammatory cytokines. These are IL-6 is the most common. Oxygen free, important oxygen free radicals, that is called as oxygen reperfusion injury. Initial hypoxic injury is subsequent reperfusion mechanism in the formation of xanthine oxidase. These are the cytokines. L6 production of acute phase release which involve immune response. These are the inflammatory cytokines. Platelet active factor, hypotension. 2-hit therapy is the role of gut. What is the 2-hit therapy? The gut is an important role in development of SARS, and 2-hit theory postulated initial cellular insult, trauma, gets up control, inflammatory response. Second insult is patient repeated surgery. Superimpose infection, bacteriemia, persistent cellular damage. Sepsis and septic shock, infection, severe sepsis, Septic shock is less than 90 millimeter of Hg. Severe sepsis, organ dysfunction. Bacteremia is blood in the toxins. Toxemia is in the septic shock is loss of gag reflex, loss of cuff reflex, ciliary function is lost, gut mucosal barrier is lost, impaired defense system, similar cell-mediated humoral immunity, gram-positive bacteria cause staphylococcus. Typical policies for Phytani, cephalometrozan, gentamicin, if unsuccessful, broad-spectrum, piperacillin, tazobactam, imipenem, meropenem has to be given. Infections on nosocomial infections, Pseudomonas are most common. These are increased European prevalence infection epic showed 25 in the infection occurred. The septic maldistribution of the blood flow classically septic shock, fever, heart rate, peripheral warm place. Management of the fluids, surviving sepsis champion management of the shock. Initial resuscitation for 6 hours begin with ringer lactates elevated. Central venous pressure should be maintained, mean arterial pressure should be maintained, urine output should be more than 0.5. So diagnosis, obtain the cultures, you do this, antibiotics, and duration of therapy typically 7 to 8 days. Source identified, control the infection from the additional criteria for the management: transfusion, pack cell volume less than 7, hyperglycemia, insulin, prophylaxis, low molecular heparin. Complication of septic shock: metabolic acidosis, multiple organ system failure, stress ulcer, pulmonary multiple organ system failure, cardiovascular failure, heart rate less than 54, mean arterial pressure less than 49, ventricular tachycardias, pH is rising, respiratory failure occurs less than 5 respiratory rate or more than 49 respiratory failure, partial pressure of carbon dioxide is more than 6.6, alveolar oxygen gradient, ventilation, renal failure, urine output is in 24 hours less than 479 or in 8 hours 159, urea is more than, creatinine is increased, hematological failure, WBC count is increased, platelet count is going down, hematocrit is DIC is there, neurological failure, Glasgow coma scale is going down, gastrointestinal failure, ileus more than 3 days, diarrhea, GIT bleeding. So these are multiple organ failure, more than one organ system damage, that is one after another, this is failure. Outcome of the multiple organ failure, if it is, this is called as prognosis style multiple extreme lower, 2 organ failures, 50% is the mortality, 3 organ failure, 80% mortality, 4 organ failure is so emphasis must be on increasing risk.